Hi, I'm David Liew from Melbourne, Australia, reporting it once again for Room Now from ACI 21, and very lucky to be joined by Cassie Calabrese, friend of Room Now, but also one of the chairs of the irAEs study group this year at ACI 21. Cassie, welcome.
Thank you for having me, David.
It's always a pleasure to talk about irAEs, one of our shared interests. And there's been a lot going on at the meeting. That this hasn't been a flash in the pan type of problem. In fact, this has got more and more sophisticated over the course of time.
That is absolutely true. It's definitely not a flash in the pan type of problem. I like that. It was nice to see. First of all, it's always a pleasure to talk about irAEs with you during this meeting, during this virtual meeting. But it was nice to see that irAEs were not overshadowed by COVID this year, and we still had so much going on. And I guess for the third or fourth annual, I don't even know, study group, irAEs study group was this morning, which is always exciting, and just honored and humbled to co-host that with my friend and colleague, Noha Abdel Wahab San from MD Anderson. And we hosted Pankti Reed from University of Chicago and really highlighted the concept of concurrent biologic therapy with immunotherapy, which is such a hot topic and rapidly growing field that we have, a lot to learn about. And they both shared kind of ongoing and future plans for investigating the impact of biologic therapy on irAEs and tumor outcomes, which is really exciting.
So let's break that down. So I guess, especially for the uninitiated, there's a bit of a dilemma here that we know that patients develop immune-related adverse events from checkpoint inhibitors. It's well known now, but and often they look like our type of problems. We want to give them the biologics that we are used to giving them, and maybe even targeted synthetics. And then the question has always come about as to what that might do in terms of the tumor response. How much of the immune response are we winding back? So I guess it's pretty clear. I mean, as you laid out this morning, there are some bits in the science which make it it's clear that it's not entirely clear in terms of where that sits, right? There might be some benefit at different points, maybe not.
Yeah, it's clear that it's not entirely clear. We have a lot to learn, but the most exciting thing is that there appears to be, at least in vitro, and as we're learning in vivo, potential for synergism with some of our targeted therapies, in particular IL-6 inhibitors and checkpoint inhibition, such that it might even portend a more favorable tumor response. And the issue is so important because these patients that develop immune-related adverse events amidst their cancer treatment with immunotherapy, that often interrupts their cancer treatment, have to stop their immunotherapy, not in addition to being terribly debilitated by the side effects that we then have to treat with a lot of steroids, which, in addition to the more well-known side effects of chronic glucocorticoid use, actually we're learning has negative implications for their tumor outcomes as well. So all the more important for us to have this discussion and learn about safety and effectiveness of targeted steroid-sparing therapy in this setting.
I mean, and it's great to see us be able to have this discussion as a rheumatology community, this idea, of course, that we can do something that will help irAEs, but also potentially even help tumor response is appealing. I mean, even at a more basic level, like you say, the idea that we can try and keep irAEs under control, even in a tumor neutral kind of way, would to keep patients on checkpoint inhibitors as long as possible, potentially life-saving checkpoint inhibitors. That's obviously also very appealing as well. It sounds like, I mean, like you laid out this morning, there's a whole load of studies that are going on in this area, driven by, right around the world and driven by various different groups. It sounds like there's some really nice work going collaboratively in this space in the US and globally.
Very much so, which was exciting to see. Not just the ongoing trials listed on clinicaltrials.gov, looking at this from both a tumor outcome standpoint as well as irAE management, but yes, NOHA presented their registered clinical trial for IL-6 inhibition concurrently with ipilimumab and nivolumab, and their really extensive experience, almost like 80, 90 patients that they've treated with IL-6 inhibition so far, which is really fantastic and amazing. And then Pankti has grand plans to look at this in a multi-center fashion, which is going to be really, really cool.
And I mean, it's clear as well from the poll that I sent out during that we're a little bit split on whether people prefer a TNF inhibitor or an IL-6 inhibitor in this context in their everyday practice. In fact, more than half of people nominated a TNF inhibitor. And I suspect, well, based on the data that you presented of your own experience and based on my own personal experience, I think people are generally a little bit split in general, right? I mean, there's all the elements of trying to navigate that. So, I mean, there was plenty of other work. Why don't you tell me a little bit about what else excited you at this meeting about irAEs?
What else? There was so much, and it was all really wonderful. A couple things that stood out for me was a nice presentation of an abstract from the Brigham that Jeff Sparks presented, I forget on which day, looking at predictors of rheumatic irAEs, which they had published at some point before this meeting, but really great data suggesting that patients with specific malignancies like melanoma and GU cancers may portend a higher risk for rheumatic irAEs, as well as patients with pre-existing like non-rheumatic autoimmune diseases, and then anyone who had been on steroids or any use of steroids within the year preceding immunotherapy. Those are all predictors of rheumatic irAE. And I think that is an evolving space and really important for us to have an awareness of these predictors for a better understanding. The perhaps most interesting abstract, in addition to, I thoroughly enjoyed Laura Capelli's session on triple M syndrome, where she hosted Ann Bass and Andrew Mammon and Syed Mahmood talking about triple M, and just kind of reiterating and reinforcing our tremendous knowledge gaps in this area. And
that's myositis, myocarditis, and myasthenia gravis for those.
Yes, thank you. Yeah. Yes, this really kind of heretofore, never been seen side effect where patients are afflicted by one or all of myocarditis, what we think is myasthenia gravis and myositis, and really highlights how much we need to learn in this space. And with the summary being diagnose early, start high dose steroids early. But to that theme, there was a really cool abstract by a group from Paris that described about 20 patients who had immunotherapy-related myotoxicity, looking to answer the question of what is actually happening in these patients that we think have myasthenia gravis. They may or may not have myositis symptoms, but then they also have this bulbar symptoms and behave very much like myasthenia. But this group looked and showed that might not actually be the case, despite a proportion of them having acetylcholinesterase antibodies. They, through EMG and even postmortem studies, did not look like those patients had like a neuromuscular junction issue on EMG, nor on postmortem like histopath. I thought that was really fascinating.
So much to learn in this space.
Yeah.
One other one I just want to kind of get your thoughts on, which was the work that was done on autoantibodies out of Hospital for Special Surgery and Sloan Kettering, looking really and seeing that perhaps, and I know the evidence is the data that's been presented has been a little bit contradictory on this, but generally has favored away from any predictive benefit of what I'd call conventional kind of rheumatic autoantibodies, rheumatoid factor, anti-CCP, but looking more at antibody signatures and the potential benefit of that. And that's a hot thing within checkpoint inhibitor, within immunotherapy and cancer. Yeah, I mean, I'm curious as to whether you think that's going to be something that will help us in the future.
Yeah, I think that was a very cool abstract, and kind of taking it to the next level, as we have, seen much work on our traditional autoantibodies, and it doesn't seem to be clear that those are very helpful. But this kind of next level autoantibody signature, which is being studied in like COVID and other hip things right now, I think that's a really cool prospect, and look forward to seeing more on that.
Well, it's all happening in irAEs. I'm sure that next year will bring some even cooler things. Thank you very much for joining me today, Cassie.
Thank you for having me, David, as always.